Sorry, we're a few minutes late. You know how technology is, this new world, having a few little issues, but thank you for joining us. And let's just get started right away. My name's Brenda Kress. I'm the Executive Director for the Sacramento Hospice Consortium. I welcome you to this exciting third part of our four-part series, Grief During a Pandemic. We have a great panel lined up for you, and here on the screen with me is Zach Woodard. He's a grief counselor for Setter Care at Home, and he's going to be your official MC today. But before we begin, I do want to thank our members, which is Setter Care at Home in Roseville, Setter Care at Home in Sacramento, and UC Davis Hospice. It's through their generous support that we're able to do series like this for you all. So that's it from me. I'm glad to see you on here, and I'm going to turn things over to Zach.
Thank you, Brenda. And thanks everybody for joining. We thought this would be an appropriate topic for today, is discussing just how the COVID has affected all of us in hospice, but also from a clinical and staff perspective, but also from the family's perspective. There's so many different precautions and barriers that we've had to face over the past several months. And so we decided it would be helpful for us to maybe have a few of our staff come on from different disciplines to tell you about their experiences out in the field visiting families and patients. So we will have hopefully a nurse, a social worker, a home health aide, a chaplain, as well as a bereavement coordinator and our children's bereavement program as well. So we're hoping to get a good discussion going. We welcome questions at any time. If they're appropriate, we'll answer them after each panelist speaks, or we might save it till the end, just depending on time. So we welcome you if you want to enter any questions as we go along. So the panel is going to talk about the various issues that they've seen out in the field, including any fears about personal safety for the families and staff and the patients as well. So, and then we'll finish off the discussion with Sarah Hickman. She's our program coordinator with Children's Bereavement Program, ART program, and she's going to talk about burnout and compassion fatigue. So I would like to start off by asking if one of our clinical staff, I don't know if Petra Wilson or Liza Raucho is on the line. Petra Wilson is one of our case managers, a nurse, and Liza is one of our home health aides. See if any one of them are on the line.
Zach, this is Brenda, and I have Petra on the line.
Okay, Petra, can you hear us?
Hello?
Hi, Petra.
Hi.
Hi, this is Zach. We're just wanting to hear your experience as a nurse, being out in the field, some of the barriers and the challenges that you've seen since the start of the pandemic, and maybe how you've been able to navigate that, or what barriers still exist for you.
The number one that I find frustrating so far is because my patients are mostly in facilities, skilled facilities, boarding care, assisted living, things like that. And so the restrictions that they put as far as getting the PPE and all that, that is not frustrating at all. What's frustrating is the watching the patients decline physically and mentally. Sorry, I'm in my car. And not being able to do anything about it because they're lacking the family support, the family touch that they were provided before COVID. So all that to me is it's a little bit frustrating, like I said, because I can only do so much. I can go in there, give them a hug and things like that, and try to listen to what they're going through, but it's not the same. What they were getting from family and friends and things like that. So that's the main
So can you talk a little bit more about the facilities restrictions for families? What are they telling families they can or can't do?
Zach, we lost Petra, so hold tight. I think she'll call me right back.
Oh, okay. I know every facility has different restrictions.
There she is.
And, oh, hi, Petra.
Hello?
Hi. I was just wondering what restrictions do the facilities have for the families? What are they telling them that they can or can't do in terms of?
They're not allowed to visit. But I go to different facilities and they're all restricted. There's some that are allowing visitors only if they get tested every 30 days. Like I myself, I have to get tested every 30 days in order to go in there. And also they're asking that of the families, sometimes they don't want them to do that like that. Or they don't have the ability to get tested. I don't know, but there's a lot of anger on the family part when I talk to them as well.
Okay.
And so that's kind of the main frustration that I have. And the only time they allow family members in is the patient is with
Petra, I think you're kind of breaking up. I can't hear you anymore.
they require to wait up focus to me and things like that, which is the only they say they don't mind doing that.
Sorry, I couldn't hear that last part. Can you repeat that last part?
Petra, this is Brenda. They're having a hard time hearing you. Can you possibly move maybe the speaker a little closer?
I have it right next to my mouth. Is that better?
Yes.
Okay. So I'm just saying that the only time they allow family members in is when they get tested every 30 days, if they're negative. And like I said, I hear a lot of frustration, anger from the family part about not being able to visit, charge, and visit with their families. The other one, the other thing I noticed, and it's a little bit, it's the frustration is on because this is just recently. The facilities are spending a lot of money on supplies. And so I feel like they're cutting down on personnel, and I hear constantly from the staff that they're short-staffed, that they're not able to do this because they're short-staffed and things like that. So that's a little frustrating as well, because it is affecting I think the care that they're providing to the patients as well. As far as personal. When it comes to personal frustrations, it's a lot of, well, there's the frustrations at home that you deal with your family and things like that. And then in addition to the ones at work, it kind of gets, some days it gets a little bit too much. And so I just have to deal with, I just have to learn to deal with how to release some of that stress so that it doesn't affect my personal life and my work life as well. So those three are probably the main big ones that I think are the most important so far.
Thank you.
Any questions?
I don't see any questions as of right now, but I do appreciate your input, especially coming from the facilities perspective, since you see a lot of patients in the facilities. Thank you for being on here with us.
No problem. Is that all?
Yeah, we're gonna move on to Liza. She's one of our home health aides, but thank you, Petra, for joining us today. All right, and now we're going to move on to Liza Raucho. She's one of our home health aides with Sutter Care at Home Hospice up here in Roseville. Is Liza able to join on now?
She was working on getting on, but maybe Margaret is ready, willing, and able at the moment. So maybe we kind of move forward with Miss Margaret.
All right, well then we're going to move to Margaret Irvin. She's a social worker, but also our regional veterans coordinator for Sutter Care at Home. And we just want to hear her perspective from veterans, but also from the social work. Margaret, are you able to get on?
You may need to unmute yourself, Miss Margaret.
Unmuted.
Oh, we can hear you now.
Okay, good. Hi, Zach. It's nice to see your face.
Yeah, good to see you. I can't see you, but good to hear you.
Oh, okay. Oh, good. I'm in my pajamas. I just wanted to echo Petra's frustration. And I think for our families and patients, the isolation and uncertainty adds to the already difficult part of, of dying. And not being able as a social worker to really go out and do the visits like we used to do the hand holding, so to say, or being present is really difficult for us and me and our families and patients as well. We're limited on who we can go see. We're really not allowed to go into facilities. We feel the stress for our nurses that have to go into the facilities, that don't have the added support from the social worker or the chaplain because they're not in there. So they're like they're a one-man band, literally.
Yeah.
So I feel that for them and what they have to go through to provide the care for a family. And as we have been saying, it's already a difficult process to go through, but to add all that on is very cumbersome. And I think it really, and Zach, you could probably speak to this later, is going to influence the bereavement process for people.
Absolutely.
Not being able to go and see your loved one. I have a 101-year-old in a board and care that isn't able to see her daughter, and she knows she's not able to see her daughter. And she calls her and says, "Why can't you come see me, Mom? I don't understand. Daughter, why don't you come see me?" And trying to explain to her what is happening. She has no sense of that reality of what's happening outside of her board and care. So her world is very, very small, and she's very isolated.
Yeah.
And I just, like I said, I can see this affecting the bereavement process for many, many families. But for me personally, it hasn't really affected my lifestyle or anything. I don't have anybody close to me that's at risk. So I don't have the fear that when I go out, I might bring something back to my family. So I'm fortunate in that regard, but I'm very cognizant of that. And I, obviously take my precautions when I do go out and see people with a mask. One of the things I think I heard Dr. Ellis, our medical director, say once was that the patient so badly wanted her to pull her mask down so she could see her face. All she wanted to do was see that face and have that connection. And I think we talked about that this morning in our psychosocial meeting. Connection is everything. And the patients that are hard of hearing, that can't read your lips. We did get some masks that are clear where it's supposed to be helpful, but then you still have the social distance. So there's a lot of new things coming to play for us as clinicians. And my hope is that we can take all of these lessons and change how we practice going forward, because we're definitely not going back to the way we used to practice. This is going to be a totally new scenario for us going on in at end of life. So that's my input.
Yeah. No, thank you, Margaret. Yeah, you brought up a lot of good points. So it sounds like you're not able to go into most facilities. So are you seeing people in their homes mostly?
I am seeing people in their homes, and I've been into Southern Roseville Medical Center to see patients occasionally, but I have not been into any facilities.
Because they're not allowing social workers in?
Right. It's only the nurses and the home health aides on some occasions, but the social workers are pretty much cut off of any of the RCFEs, the ALFs, SNFs. We're not in there.
Wow. Yeah, that is a lot on the nurses. If the families, the chaplains, the social workers can't visit to provide more support, it's a lot for the nurses to handle.
Absolutely. And like I said, they're a one-man band, and I'm sure they take all of this with them. They can't say, well, they call us. I mean, we can call families, but again,
Right.
like we said, it's the connection. It's different from even this forum, being able to sit, with you, Zach, in your office and have a conversation with you is so different now. And for us to call the families, we can do that. But sometimes I think there's a disconnect because we're not providing the presence.
Right.
And that's what they need the most. And then, like I said, the nurses really, they've got a lot on their shoulders. They truly do. And just, gowning up and going in there, and then how do they process everything when they're done with that visit? Where do they put all of that?
Right.
So, and I know our bereavement team has been working really hard on providing support for them, for all of us. But I think we all really are concerned about our nurses.
Yeah. Yeah. I'm sure it's weighing on all of them and all of us. Absolutely. Yeah. I was going to ask you too, from a family's perspective, I heard in some meetings that maybe some of the staff are helping families connect with their loved ones in the facilities. Have you heard anything about that?
Yes, I have heard that some people are using FaceTime and different things like that. And I think that, overall that's a good practice. But again, you have a 101-year-old and you want them to FaceTime, or, they get a little confused. I can't even hardly use Zoom, Zach. I can't expect, some of my elderly patients to do it.
Right.
So, I mean, it is a struggle. But there are some families that are using technology to connect with their loved one. And you've heard the stories, I'm sure, of how the facilities will put their patient up to the window and the family visits from the sidewalk. They hold up signs. They have parades around the facilities with the cars honking and balloons and stuff. So like I said earlier, I think we need to rethink how we practice, because it's not going to be the same as it was. And we might have more of those parades than we ever wanted to have. But we've got to be creative.
Right. Right. Yeah. Well, I think, let me look and see. I don't know. I see a question here. It says, this question from Chris says, if a patient is determined to be a hospice candidate, then are families taking their family members home, even if against medical advice? Margaret, do you have any?
Well, I haven't had this case, Zach, but I've heard it from our branch in Roseville that they have had patients come home from the hospital because the families could not get in to see them. And they're like, well, we're just going to bring them home on hospice. So that, I have heard of that. I haven't personally experienced it, but I've heard it in our branch.
Okay. Great.
Zach, this is Brenda. There's also a question in the chat. I don't know if it was addressed from Diana. Are there some families withdrawing relatives from the facilities because of isolation concerns?
Margaret, do you have anything to add to that question?
I would not be surprised about that. And we were just talking today in our meeting again at how the difficulty we're having getting patients into facilities for respite care. And that's the flip of the coin. Some people are taking their loved ones out to bring them home because of the concerns. And then there's some that are trying to get them in and we can't find beds. And people need respite. I mean, things happen and they have to have that. But the facilities, which is understandable, have really strict restrictions from the state.
Right.
So it's a double-edged sword.
Right. Yeah. Yeah, it's because obviously families, not all families have the ability to care for their loved one at home, especially if they're elderly and their loved one requires more physical help. And it puts them in a difficult position of whether to, and even if they have the option, it sounds like that's not an option for a lot of people, is because of the restrictions of moving people into a facility. Right.
And as you know, caregiving is overwhelming. And then we have families that are homeschooling their children at the same time. So, it's very complicated and complex. So, yeah.
Well, thank you, Margaret. I really appreciate you jumping on here.
You're welcome. You're welcome. Like I said, it's good to see you, Zach.
Yeah, thanks. Good to hear from you. And now I think Liza is on. Liza is one of our home health aides with Sutter Care at Home. Liza, can you hear us?
Yeah, can you hear me?
Yeah.
Okay. Hi, Zach. How are you?
I'm doing well. We've got a good turnout. And so we're just talking about, what's your experience being out in the field, seeing patients, seeing families, now that we're in this pandemic? What has been your experience through all this?
Oh, it has been overwhelming, stressful, but as a parent, no matter what, and a daughter of an elderly woman, and, caring for families and with patients and caring for them as family members too. There's nothing in between all that. It's just your job's never done.
Yeah. Sounds like you've got a lot
you're
on
waking up, caring for yourself, caring for others, making sure they're in good perspectives, good mind, good health, and then you go off to do work and do the same thing just to get off work and do it all again at home.
So it sounds like you've got a lot on your plate before and
Oh
after
yes.
work.
Yeah. And during this time it can be overwhelming. But the good thing about it is knowing that you're educated enough to help ease families with their loved ones at home.
So can you tell me what you mean by that?
Making sure that you're staying safe and us having our protection gear and our testing and all that. And then, ensuring the families that you haven't been around and that you're educated every morning with our meetings. And then you are keeping them safe, and we're with a routine with them, and educating the families, reminding them the importance of everything. And so, yeah, it's an everyday routine thing.
Yeah, it sounds like it. It sounds like it. And so for you, are you able to see very many patients now?
I do. There's I have blessings now and then that I'll get a few helpers helping with our visits. And so I'm so grateful for those.
Yeah, yeah.
Yeah.
And it sounds like you're providing more support too, because maybe the family's not able to visit if you're in a
Yes,
facility.
that's right.
Yeah, so it sounds like you're providing emotional support, maybe even more to
Yeah.
families and to
Oh yes. Yeah. And it's really important for the nurses with the family members that it gives them closure, but also it gives the family relief that we come out and we're out there giving their loved ones the time and affection, and they're happy to see somebody new twice
Yeah,
a week. So they're like, oh great, I'm glad to see you.
yeah, I'm sure,
Yeah,
especially if they can't see family, I'm sure they're,
that's right.
yeah.
So
And I don't know if you want to speak to this, but in your personal life, how has that been affected by the pandemic?
oh, stressful,
Yeah,
but I'm just looking forward to when it's eases down a bit and we get more answers to everything.
yeah.
I mean, time will only tell, but I just try to make the best out of it. So the only way you can do that is when I have a day off to pretty much shut off every electronic there is around, meaning TV, the phone,
Yeah,
and just shut the world out and just go for a nice drive or
yeah,
go somewhere where nobody else is around, to just spend quality time to try to feel normal again.
right. No,
Yeah.
that's a good idea. I think that's good advice.
Yeah.
That,
So fortunately, I love being around people, and we can't be around too many of them. So
yeah, right.
there's a lot of driving by to say hi to your friends.
Yeah. Well, and especially a social person like you, I'm sure.
Oh yeah,
Very hard
especially
to
I'm
not.
having withdrawals.
Yeah.
Sometimes I get tired of looking at my kids.
Right.
I tell them, go away, go out front, go to the back for at least 20 minutes.
Yeah. Right. Well,
So
thank you, Liza. Did you have any other
yeah.
last thoughts or comments?
No, just trying to hang in there, and just can't wait till all this is completely over, if it will be. But
Yeah. Yeah.
hoping for the best of it all soon.
Yeah. Yeah, we all are. Thank you. Thank
Yeah.
you, Liza, for jumping in here and sharing with us.
Thank you. It's good seeing you, Zach.
Thanks. It's good
Look
hearing from you.
good.
Yeah, thanks. It's good hearing from
You should be the face Zoom model.
you. All right, Liza, thank you. All right,
Bye.
so, bye, Liza. We're gonna now shift over to one of our chaplains with Sutter Care at Home, Jeff Richards. And he's going to kind of share his perspective in providing spiritual and emotional support to families and the patients. Jeff, are you able to get your video on?
Yes, look at that. Wow. Yes, technology is yes, fun. But no, glad to be with you all and yeah, talk about the challenges that we face in this time.
So tell me about what's
yeah. Well, I actually kind of prepared some thoughts, but basically it's felt like I've been kind of wearing a like a cloak or a shroud kind of since March. And kind of realizing that's been, kind of several months now.
Yeah.
And sometimes I don't notice it. And I'm still able to, be in the moment and provide care, and bear witness to beauty, connection, and feel hope and joy. But the extra layer is just kind of there. And I felt, and still do, I feel grief, anxiety, worry, and fear. Imagine folks might be able to relate to that as well. Like others have said before, facilities are, a number of them have precautions or straight up kind of restrictions. Fortunately, in some of the assisted living places, I've been able to still see people, wearing, sometimes I'll wear just a surgical mask. Other times I'll have, goggles or the N95.
Oh, when would you wear the goggles and N95? Is that with people who are more at risk?
Yeah, more at risk, or if they're, under investigation for perhaps having COVID-19, where, they've maybe had a family member who's had a 100-degree temperature or something along those lines. And so we put on protective gear. I don't, because I don't have to, I usually get close, like someone mentioned, earlier, to be able to, for someone who's hard of hearing. But other than that, I'm not normally, I'm not like a health aide or nurse that's, checking, their bed sore or something like that. So I'm not like, all the, on their body, even though I'm, will certainly provide gentle touch on a shoulder or something like that, or maybe even a forehead. So I actually was realizing I've started to use the phrase in-person visits for when I can actually go in. It used to be like the opposite of like, well, I'm doing like a phone visit or what have you, or a video. So it's interesting that phrase now is actually like a demarcation of what I'm able to do or the type of visit I'm able to have.
It sounds like most of your visits are phone now.
I'm actually right now. Well, this is part of what's been hard is that it just changes. Depending on the patient or who we're providing care for, or the family, depending on what seems to be happening in our community in terms of the virus and how much that's like increased. There was a period where everyone was sheltering in place, and we slowly started to kind of open things up a little bit, and we saw that as well. And then it started to kind of skyrocket again. So it's just, it's like every day, every moment, which I suppose is always true anyways, that we never kind of know exactly what's going to happen and what have you, but there's just this extra layer of unknown that I'm always kind of dealing with.
Yeah, you described that as like a shroud. Is that what you said?
Yeah, or a cloak. I've been trying to like reflect and think about what it is, and I think in some ways it's a mixture of of fear and anxiety, or just grief. Like there's just this layer of grief, of things not how they were, of the unknown, even being worried I'm gonna pass it to perhaps my wife. So there's just just this extra sort of layer, and that doesn't always kind of limit. I mean, that certainly, if I get stuck there, that kind of can inhibit my caring for other people, and really being present and listening to them, and helping to sort of feel what they're feeling, and help provide some space. But it also allows moments of just kind of shared sacred space, even with goggles or a mask. There's one daughter was remarking how it felt like for her, that like it was in the room with her mom, who was actively dying, and she ended up dying, I think, the next day. It felt like a thin space, and just this beautiful, where like it was sad, and yet it was also joyous, and it was also beautiful, and she felt connected to her mom and her family. And so even with the barriers and challenges, it doesn't always stop the goodness that we've witnessed and that we see, and thankfully are still able to, even in the midst of the kind of challenge and the barriers that we face.
Yeah. Well, and I'm sure those experiences help you keep going too.
Yeah, absolutely. It would, it's a bit of a fuel. Well, certainly. And trying to do my own kind of self-care, if you will, of taking moments of connection for myself, enjoying kind of nature. Fortunately, I have a backyard that it's not huge, but we're right next to a park. And so anyways, there's just bits of nature, we're able to do. We even bought some houseplants. We've never had houseplants. but just this bit of nature and normalcy is grounding and is helpful.
That's good. Yeah. Well, like you said, even if it doesn't affect your work, I'm sure it affects, going home. And so it's like you need to be
this kind of, I've noticed the level of I have like a shorter ability, a smaller space, a smaller margin of where I get angry, or frustrated more quickly, than I've been. It absolutely, the grief and just the extra precaution, and feeling like I have this thing around this, this COVID canvas, it's there. So it certainly affects me emotionally in the relationship with folks. And yet even like I was texting some friends, about some other like personal issues with my family, and just that even through a text, like just the outpouring of love and care, at least for that moment, for a little bit after that lasted, was just the balm that I needed. So it's there's sort of this both and of the messiness and the grief, and opportunities still where the light kind of comes through.
Yeah, no,
so
that's a great way of putting it. Be able to hold both and hold both the
that's a challenge. But sometimes it just happens, good things happen and people feel cared for, even by wearing the mask. It feels weird, and it's a reminder in some ways to me when I take it on and then take it off, that there's this issue we're dealing with, and yet people feel, I've heard from folks where they feel cared for. They totally understand that it's, having the goggles, it's a protective thing. And so they're almost sort of like grateful that, that we're taking those measures for ourselves as well as for others.
That's great. Did you have any other comments, or I'm going to see here if we have any questions?
Yeah, sure. No.
Yeah, I don't see anything right now. Well, Jeff,
Okay.
I appreciate you sharing your perspective, and
Yeah,
definitely,
you're
I
welcome.
think you've got some good insight on especially self-care and being able to hold both the good and the bad during this time.
Yeah. Thanks. Well, yeah, I'll be around if anybody, has specific question that I can help answer, or we'll see. So, but
if anybody has any
I'll
questions, we'll answer more at the end. So feel free to put them in the chat or the questions box.
Cool. Thanks so much.
Thanks, Jeff.
Oh.
All right, now we're gonna hear from our bereavement coordinator, John Campaglia. He's gonna share his experience of caring for families and bereaved. John, can you hear me?
Yeah, hey Zach, thank you. And yeah, so I'm gonna echo quite a few things I think that some people have already said. And I'm gonna focus in a little specifically on kind of the family's experience and give some more examples. I will touch upon, like what we're doing a little bit, but I just wanted to give kind of more in-depth, introduction to that. That's also going to be the topic of our final panel, grief during COVID, both anticipatory grief and after the death. So I don't want to go too much. But I think there are a lot of really kind of specific types of grief that happen sort of right leading up to death and right after that are, of course, are unique to right now. And so, yeah, that's where we're going to go. There's many. I'm only going to touch on a few. But, for instance, if a patient's in a hospital or facility, like everybody's been talking about, there's the extremely restricted access. I've heard stories of people having to drop off their spouse at an emergency department and then not be able to go in with them. So imagine that, your loved one's on hospice and you're preparing for them to die, and now they're having a medical emergency, which is significant enough to bring them to the emergency department, right? Which we don't normally do in hospice. And then you're told to sit in your car, and wait for an unspecified amount of time. Whereas normally you'd sit with them in the waiting room, you'd hold their hand, and you just can't do those things. And so for many people, that I've talked to, things like that, it brings up, sadness at imagining them all alone, anger or frustration, even, worry about people with potentially having COVID in where they are, even guilt that they can't be in there with them, even though they can't, even though there's not an option. Then there's kind of the thing about once, a person's loved one is in a facility, whether it's a hospital or a board and care or a, skilled nursing facility, they can't spend the same amount of time, right? So that's a big one for people. And again, this kind of flies in the face of what they would normally do. For many people, they'd spend as much time as they possibly could with their loved one. I've certainly talked to people in the past that, are there 7 to 10 hours a day at a facility with their loved one. And so there's that, there's that separation. As someone else mentioned, maybe if they're lucky, the person has a room on the first floor with a window and they can see them through the window. And, I've seen this firsthand. Just a couple weeks ago, my great uncle passed away, and I'm close with his, children and grandchildren. And when COVID first started, they couldn't be in the facility for 10 days. They could not see him, and he had advanced dementia too. So even when they could see him through a window, there was, this further sense of separation, kind of multiple levels of separation, physical, but then even the being able to touch him and, I think another part of what was interesting with that is at the beginning, for instance, the facility wouldn't even let hospice in. for like 7 days, 10 days. So, you know, this man who's getting towards the end of his life didn't get his pain medication for 10 days, you know? And so, you know, I know that's complicated, you know, she's I guess my second cousin, you know, her grief, because she's also dealing with now, like, is this a lawsuit issue? You know, all these kinds of things, you know, because of the added discomfort, and they were maybe doing something they weren't actually quite supposed to be doing. So there's that, you know, and then kind of taking it one step even further, you know, a lot of people are finding that they will get to be with their loved one maybe when they're dying. You know, the facility will let them in for that. And so, of course, that's good. And I'm glad that facilities are doing that. And I think people appreciate that. But I've also run into things with people, because they're not already at the facility like they would have been, you know, not being able to get to the facility on time before their loved one died, right? So that adds this extra level of sadness, grief, you know, anger perhaps, you know, sometimes at themselves, sometimes at the facility. So again, it's like adding these, you know, sort of uncommon levels and layers of grief. And I think, you know, I want to, you know, pause for just a moment and say something that we see in grief all the time, but it's kind of emphasized right now, is this issue of guilt, which I've touched on a couple times. A lot of people, you know, guilt and regret is something even in normal times they'll feel. And not just because like they didn't say the things they could have said. People who are totally there for their loved one, you know, totally involved, can still, you know, go through these times in their grief process where they're kind of reflect, I wish I had done that. I wish I hadn't done that. I wish I'd known that, you know, and it's something they have to work through. But then, you know, during COVID, you know, these kind of issues and emotions are just exacerbated. Yeah, I've had a couple people say things like, I think I mentioned this maybe, like, I should have somehow forced the hospital let me in, or made the facility let me in, you know, which again, you know, I think that's the thing sometimes about grief-related emotions. They don't have to be what we would consider logical, right? They just kind of, they are what they are, and they come up, and things like this, whether it's not being there when they die or not spending as much time or whatever, just really complicate that. And so I think I'm at about time, right? Are we getting?
Oh yeah, you've got a couple more minutes if you unless you're done. Yeah.
You know, maybe just one other thing I'll mention real, you know, kind of quick, is that one thing that comes up for a lot of people right after the death, right, is the way that celebrations of life, funerals, memorials, you know, homecomings, as some traditions call them, are interrupted, right? You can't have a graveside funeral sometimes. You know, I've had people who had to rent a drone to videotape their loved one, you know, going through this process. Many people would have had a big party, and that's what their loved one would have wanted, right? And they can't do that. If they do it at all, it's a few people, and there can be a lot of sadness there, you know. And plus everybody's, you know, wearing their stuff, and, you know, if they are there and there's that sense of separation there, maybe they're not comfortable hugging, all these kinds of things that you would naturally do. And I think kind of the underlying is, you know, these are big kind of life passage, you know, rites of passage issues that people get a lot of meaning for, both in the sense of the stories they hear of their loved one, the connections they make with people there, but also oftentimes people describing in normal times kind of the sense of a certain kind of sense of closure they get for honoring their loved one in this way. And, you know, that this is just makes this time more difficult, you know. So, you know, I kind of weighed out all those things. Of course, in grief counseling, we address all these. You know, we recognize, okay, well, right now this is part of their grief, and we give people a chance to process. We hold space for it. We ask questions. You know, we recognize that there's complicating factors right now, and we honor those. You know, I mean, that's what we can give to people, and that's what we really try to do, is really normalize kind of these extra levels of grief that come up that are specific to this time. So thank you.
Yeah, thanks, John. I appreciate you jumping in and sharing that perspective. And like you said, we'll talk about it a little bit more deeply next in 2 weeks and the final panel about the bereaved and how it's affecting them. Thanks, John.
Thank you.
And last on our panel, we have Sarah Hickman. She's the program coordinator for the Children's Bereavement Art Group. And let's see. Oh, there you are, Sarah.
Hello.
Hi.
All right. Well, thank you for having me back. And when I was thinking about preparing for this panel, I thought that my time could best be used to introduce 3 terms that have been really helpful for me as a helper, as a therapist. And so I'm going to use the word helper. And when I say that word, I mean really anybody who's listening today. So whether you're a chaplain or a nurse or a bereavement counselor, a home health aide, anyone who's supporting others during this pandemic, a volunteer, a parent, a teacher, this is for you. And so John talked about normalizing, and what I hope I can do today by introducing these 3 terms for you is to normalize your experience as a helper and give you an opportunity to check in with yourself in some different ways. So the first term I want to talk about is burnout. And I'm saying that with a little bit of a smile on my face because I think we all know this term and we may use it even a bit flippantly. Oh, I'm burnt out on that, or I'm burnt out from this. Unfortunately, right now, we are all at risk for burnout. And burnout tends to happen when we have systemic changes at work or in our volunteering, management changes, an increase in workload, or changes in financial strain, or in our case, a global health crisis. And so some symptoms of burnout can be anything from fatigue, tearfulness, increased worry, low productivity, or my personal favorite, which is when someone cancels, feeling a sense of relief. I think we all know that this work brings us meaning, and we all have probably some beautiful stories as to why we were drawn into this work. And yet those moments when someone cancels and you feel better, those can be a sign of burnout. So the good news is combating burnout, there's a couple things that we can do. First and foremost, during the pandemic, it's really important that we all give ourselves permission to have days where we're not productive, days that we're not going to be the best nurse, we're not going to be the best chaplain, or even the most present volunteer. We're under so much stress and having to learn technology. It's important that we have moments where we pat ourselves on the back and say, I showed up today and that was good enough. That's enough. So another way to combat burnout, though, is to take time off. Most people who are truly suffering from burnout, when they have time away or when their work or kind of tasks at their helping position change, when they return to the work, they tend to feel refreshed. If you have that experience where, say, you take 5 days off, you come back, you feel a lot better, you were probably suffering from a little bit of burnout. So the next term, oh, and I forgot to mention that burnout also accumulates over time, and that's important for the next couple terms. The next term I want to introduce you to, you may have heard before. It's really, really important for helpers to know this term. It's called compassion fatigue. And compassion fatigue is essentially chronic stress that builds up over time from putting other people's needs before your own. And as someone mentioned earlier, you know, the experience of moving from caring for patients to moving home and caring for children, caring for loved ones, this is going to be exponential right now during the pandemic. So many of us may be suffering from compassion fatigue. Some of the symptoms of compassion fatigue are difficulty transitioning. So difficulty going from home to work or vice versa, blaming others, feeling angry, feeling frustrated, and then some of those lower productivity symptoms similar to burnout. But the trick here is that time off isn't necessarily the only thing that's going to help or the only thing that we need when we're suffering from compassion fatigue. For compassion fatigue, we need to look inward and to have opportunities for reflection. one thing that we can do is examine our boundaries, right? To think about, okay, is this a period where I could have said no, an opportunity to say no? Should I really be taking on this new project? As much as I want to help people, as much as I want to be there for everyone right now, should I really be taking this on? So those are times when we can say no, are examples of looking at and managing our boundaries. Another thing we can do for compassion fatigue is setting ourselves up to cope ahead. What that means is calming, not numbing. So knowing that after work, we all really maybe want to watch Netflix, use substances, eat comfort food. I definitely don't want to be judgmental about these behaviors, but these are kind of like numbing behaviors, right? They zonk us out from the pain and the stress that we've encountered during our helping role. And what we really need for our compassion fatigue is calming. And so that looks more like journaling, making art, being in nature. Someone mentioned earlier, shutting off all of your electronics. That's a beautiful example of calming, connecting with others. If that feels, not exhausting, maybe just talking to one friend in nature. Or my personal favorite, staring at a blank wall, which I've learned is a part of mindfulness. But for those of us that aren't, experts at mindfulness meditation, you can just find a blank wall to stare at. That can actually be pretty calming. So the last term I want to introduce you to is vicarious trauma, or some of us may know it as secondary traumatic stress. Vicarious trauma does not come on slowly. It can come on suddenly, and it can happen to anybody. It is not, and none of these are an experience of someone who is green or amateur in this field. You could be here for 30 years or 30 minutes, and you can experience all three of these things. Vicarious trauma is essentially the emotional residue from exposure to traumatic material, such as fearfulness, illness, shame. And you can imagine that we're all experiencing a lot of that right now. We heard that today. The trick with vicarious trauma, though, is recognizing the symptoms. So unlike compassion fatigue and burnout, these symptoms mimic post-traumatic stress. You might feel easily startled, have some free-floating anger, you're not really sure where it came from, insomnia, nightmares, preoccupation and tension, thinking about your clients or patients, rejecting physical closeness, and then, of course, moving into substance abuse when things get more serious. Similar to compassion fatigue, what we need when we're experiencing vicarious trauma is to look inward, to have opportunities to set boundaries, to calm, not numb. But the other thing that we need if we're experiencing traumatic stress and vicarious trauma is to talk to a professional. So I hope that if you are having some of these symptoms, that you can check in with yourself and think about contacting a counselor or psychotherapist, someone that you can talk to about them, because you absolutely can have ways to minimize them. And it is something that's completely treatable and normal that can arise from this difficult work that we do. And one thing I will add, as an art therapist, we see just really, really great results from the creative practices, whether it's movement, drawing, music. I mentioned this on the last panel that I was on. All of these are fantastic ways to manage exposure to traumatic material. So in conclusion, I hope that sharing just these three terms, burnout, compassion fatigue, and vicarious trauma, gives you an opportunity to check in with yourself. I know it's definitely something that I'm doing as well during this time, and can lead you on a path towards a little bit better coping on the day-to-day. So thank you.
Thank you, Sarah. Thank you. That's very helpful for me. I'm sure it's helpful for everybody on this call as well. I don't see any questions at the bottom or in the chat. So I think we're going to go ahead and end the call. I just want to thank you all for joining us. I want to remind you that the Sacramento Hospice Consortium is going to hold their final panel in 2 weeks. And this one's going to be discussing grief. What's grief like for people who are grieving during this time of COVID-19, or those who are anticipating a loss on hospice. And from, you'll hear from some of our counselors and some other staff about that. Thank you for joining us, and I hope to see you all in a couple weeks.